Welcome. Today, we're going to dive deep into musculoskeletal medications. But we're not just going to list facts. We're going to visually map out the why behind how these drugs work so you can actually picture the pathophysiology in your head. Trust me, it's going to make all the difference.
Okay, so here's our game plan. We'll start with muscle relaxants, then jump into anti-gout meds. After that, we'll cover the heavy hitters, the DMARDs for arthritis, and then osteoporosis meds. And we'll wrap it all up with the nursing priorities that you absolutely have to know. Let's do this.
First up, muscle relaxants, for those really painful muscle spasms. The key here is figuring out their pathway, because that's going to tell us everything we need to know about their side effects.
So here's the big question, right? A patient's in pain, their back is locked up. How do we get that muscle to just let go? Well, it really comes down to where we decide to intervene. Do we go right to the muscle itself, or do we go to the command center, the brain and spinal cord, and tell it to cool down?
Think of it like this. The centrally acting drugs, they're like a citywide curfew. They send a message to the entire central nervous system to just calm down. And that includes those overactive nerves causing the spasm. Peripherally acting drugs, on the other hand, are more like a special ops mission. They go straight to the muscle fiber and cut off its power supply, which is calcium. So it literally can't contract anymore.
And this brings us to what is probably our #1 concern, patient safety. Because these drugs are hitting the brakes on the central nervous system, they're going to cause drowsiness, maybe some dizziness, and what does that mean? A major fall risk. So we've got to be on high alert.
Oh, and here is a huge exam tip. You have to keep an eye on the liver. Why? Well, the liver's job is to break these drugs down, and for some of them, like dantrolene, that process creates byproducts that can be pretty toxic to liver cells. That's the pathophysiology behind monitoring those LFTs. We're looking for any sign of liver stress.
Okay, so we've covered calming down muscles. Now, let's switch gears to a totally different kind of pain. Gout. I want you to imagine tiny, sharp, needle-like crystals forming in your joints. Yeah, ouch. Our entire goal here is to stop that from happening by getting a handle on uric acid. You can think about this as a simple supply and demand issue. We've got two main strategies. We can either turn down the production at the uric acid factory with a drug like allopurinol, or we can open up the exit doors wider with a drug like probenecid, which tells the kidneys to just get rid of more of it. Either way, the end goal is the same: lower the amount of uric acid floating around in the blood. This slide is packed with classic exam questions, so let's walk through it. First, we need to flush those crystals out, so lots and lots of fluids. Makes sense, right? We also want to limit the building blocks of uric acid, so that means cutting back on high purine foods. But here's the critical one: no aspirin. Seriously, aspirin basically creates a traffic jam in the kidneys, which stops uric acid from leaving the body, and that can be enough to trigger a really nasty gout attack.
All right, now we're moving on to the big guns, DMARDs. These are not your average pain relievers. These drugs are designed to go to war with rheumatoid arthritis and stop its destructive path right in its tracks. We're talking about intervening in an all-out attack from the body's own immune system.
Okay, this image is a bit intense, but it's so important to see what we're fighting against. In rheumatoid arthritis, the immune system goes haywire and attacks the joints. This unchecked inflammation creates something called a pannus. It's this destructive layer of tissue that literally eats away at cartilage and can eventually fuse the bones together. Our mission with these drugs is to prevent this from ever happening.
And that's where DMARDs come in. They are the heroes of this story. By putting the brakes on that overactive immune response, they can halt that destructive pannus, save the joint, and honestly, change a patient's entire quality of life. They are true game changers.
But here's the catch. There's always a trade-off. When you suppress the immune system, you're leaving the patient vulnerable. You absolutely have to know these adverse effects. Methotrexate can shut down the bone marrow. Hydroxychloroquine can cause permanent eye damage. And drugs like etanercept open the door for all kinds of serious infections. These are life-threatening risks.
All right, let's shift our focus now to our bones, and specifically osteoporosis. At its core, it's a really simple imbalance. The body is breaking down old bone faster than it can build new bone. And the result? Bones become fragile, brittle, and can fracture from something as simple as a fall. This next part is all about one simple, but absolutely critical idea. These medications can be incredibly harsh on the esophagus. Just imagine a pill getting stuck in your throat and causing a painful chemical burn. That's exactly what we are trying to avoid. And that's why how we give these drugs is so incredibly important.
So here's the 3-step safety protocol. It's non-negotiable. Step 1, take it on a completely empty stomach to make sure it gets absorbed properly. Step 2, swallow it with a big, full glass of plain water to help wash it down. And step 3, the big one. The patient has to stay upright, sitting or standing, for at least half an hour. We've got to use gravity to make sure that pill gets all the way down to the stomach and doesn't hang out in the esophagus.
Okay, it's time to put it all together. Let's run through a couple of exam-style questions. This is where we take all that pathophysiology and connect it directly to what we do as nurses.
Let's test ourselves on that administration procedure we just covered. Thinking about that risk of esophagitis, which one of these instructions is the only safe choice for our patient?
Yep, you got it. It's number 3, taking it right after getting up with a full glass of water. Taking it at bedtime or lying down after, that's a recipe for disaster. It dramatically increases the risk of that pill getting stuck and causing some really serious damage.
So, let's boil it all down to these 5 golden rules. Think of this as your final checklist. Number 1, always prioritize safety with those drowsy-making muscle relaxants. 2, always monitor the labs, liver and blood counts. 3, nail that patient education for bisphosphonates. 4, be vigilant for infection with DMARDs. And 5, know your interactions. Every single one of these rules ties directly back to the why we've been talking about.
And that really brings us to our final thought. This isn't just about memorizing facts for a test. It's about truly understanding the why behind what we do. When you can visualize the pathophysiology, you're not just a better test taker, you are a safer, smarter, and more effective nurse.